In the coming 15 to 20 minutes, I'm going to talk about some of the results we found in the clinical commissioning of the ClearRT in our centers. First of all, what is ClearRT? ClearRT is actually a new feature in tomotherapy for positional verification. But everyone knows we use Mvct nowadays for positional verification. So that's actually is another option for the imaging. The acquisition method is very similar to what we have in the diagnostic CT. So it used the helical fan beam to acquire the projection data for the reconstruction with a kilovoltage photon beam. The major difference between ClearRT and helical KVCT is the use of a fat panel detector instead of multiple rings of small detectors in diagnostic CT. As you can see, the comparison between the cone beam CT and the ClearRT, cone beam CT use a wide cone beam for the image acquisition is in the stationary mode, but ClearRT use a collimator beam, and the acquisition is done by the helical acquisition. With the collimator beam, we can expect a little bit less scatter radiation to the field, so maybe that will improve the image quality a bit. With the helical fashion of data acquisition, we also have the flexibility to have different scan length coverage. We can have a shorter, longer scan length coverage and give us more flexible for different kinds of treatment. There's also some difference between the Mvct and the ClearRT, although they look very much like the same in the acquisition method. But definitely we use different energy for the photon beam. We are comparing kilovoltage photon with megavoltage photon. The other difference is the collimator size or the jaw size. ClearRT use a much wider jaw size. We are talking about a couple centimeter wide field size as compared to few millimeter width in Mvct. So when we are talking about like image modality, the evaluation of a new image modality must be involved two things. One is the image quality assessment. The other thing is the radiation dose to the patient assessment. We use different phantoms in the image quality assessment. The first test we did was the uniformity test. As you can see from these slides, the result from ClearRT is actually very good. It's highly comparable to what we had for the Mvct. Although we don't show it here, the cone beam CT result is actually highly similar to whatever we have for ClearRT and Mvct. So the conclusion is it doesn't matter what image modality you use, you always get a very uniform, good image. How about the no contrast resolution? We then changed to use the cut-fan phantom. Because of the basic physics, using kilovoltage comparing to a megavoltage, we have much better tissue contrast. So it is expected to have a better performance in the ClearRT and the cone beam CT comparing to Mvct in terms of the low contrast resolution. Maybe because of the scatter radiation reduction in the ClearRT collimated acquisition mode, then we see some little bit advantage using the ClearRT than the cone beam CT too. With different inserts of different materials in the cheese phantom, then we measure the contrast to noise ratio and the signal to noise ratio. As you can see from the table, ClearRT actually has overwhelmingly better signal to noise ratio than Mvct and cone beam CT. And the signal to noise ratio are actually comparable between Mvct and cone beam CT. So with high signal in the ClearRT and a better contrast in the ClearRT. So it's no surprise to see a better result we have for the contrast to noise ratio in ClearRT than cone beam CT and Mvct. Because of the kilovoltage acquisition, of course, we have a little bit better, actually not a little bit, but a lot better contrast in the cone beam CT than Mvct too. So talk about the image quality, then we have to also link it with the radiation dose. I don't have the full list of the scanning protocol here because it's a long list, but you can see the dose depends on what image protocol or what imaging parameter you use in the acquisition. Like you can have more, less comparable dose in terms of the multiple slice average dose, comparing ClearRT, Mvct, and cone beam CT. So basically, it depends on what imaging protocol you use. So I guess it's more fair to compare the most used protocol in our hospital with the most used protocol for Mvct. As you can see from this table, we have a little bit less or comparable dose from ClearRT to Mvct in terms of the CTDI. But one thing we have to bear in mind, the jaws opening is much wider in ClearRT than Mvct. So if we use another dose matrix, very commonly coded dose length product, which is actually the product of CTDI times the scan length, then it is another story because we always have a little bit overscan in the inferior side and also superior side. So make the DLP a little bit more like favored for the Mvct because the collimator size is a little bit much smaller. Still, looking at the result we got from our survey, we still have a little bit less dose for the head thorax region, but we actually give a little bit more dose to the pelvis region. So I guess it's our center choosing the imaging protocol that we cannot see any dose saving or dose benefit from using the ClearRT. If other centers use other imaging protocol, then maybe they can have some dose saving or even different results. So using whatever like imaging protocol we prefer, then we get a very clear image. Although we don't see any dose saving from our protocol, but the image quality is much better. You can see from this clinical example, the image is much nicer than the Mvct, the noise is less, the contrast is higher. We haven't done actually a study on the accuracy of the position verification due to the clarity of the image, or doing some time measurements, see how much time saving we have for the RTT to do the image matching. But I'm sure a clear image, a better image will give the RTT more confidence and maybe lead to a more accurate image matching and also save a little bit time when they do the position verification. How about the scan time? The scan time is definitely much shorter. As you can see, we are talking about tens of seconds instead of minutes in Mvct. This saving in the scan time actually, in my personal perspective, is the major advantage of ClearRT. Because it will potentially improve the patient throughput and also increase the patient comfort. That makes a lot of difference when sometimes you need to repeat the scan, or you have a patient with like multiple sites of tumor, then require a long scan length, then that helps a lot. Like other KVCT technology, we suffer from all kinds of artifacts in ClearRT, scatter artifacts, motion artifacts, beam hunting artifacts. So we see some advantage and disadvantage using ClearRT. So what exactly the final conclusion of the comment in the ClearRT? We asked 6 experienced radiation therapists to help us to do image quality scoring test, and the overall score favored ClearRT. And actually, since the installation, almost all the patients we treat in our center use ClearRT for the post-surgical application, except for few exceptional cases. So I guess the RTT actually likes to use it more than Mvct. One of the applications of ClearRT is definitely for adaptive radiotherapy. According to APM-TG 148, we have to get a relatively stable CT number for a daily CT. And as you can see from this table, ClearRT actually fulfills most of the requirements except for the bony structure. The variation is a little bit higher than what is required by APM-TG group. So does it mean we cannot use it for post-surgical applications? We then performed a single case study for 3 regions, head, thorax, and pelvis, and see whether we see any big difference or dosimetric impact of the ClearRT due to the CT number variation. We didn't find any significant impact. So I guess we're still okay, even we have some violation of the CT number variation in the bony structure, but still we can use it for adaptive radiotherapy. There's one unique artifact in ClearRT that you will not see in cone beam CT or diagnostic KV-CT. It's due to the long longitudinal density discontinuities. The cause is because in the reconstruction step, it used the adjacent slice information for the reconstruction. So if you have an interface between the air and the soft tissue, then you will end up having the Huntsville unit depiction, just like what you see in the Phantom study. And also this effect will be seen in some of the clinical case too. For example, in the middle, you see some dark area in the brain, and also you can also see that in the shoulder. So does it really matter? How does it affect our clinical results? So we did a Wendell Phantom study to evaluate the dosimetric accuracy. We created 5 pens with the targets located in brain, nasopharynx, shoulder, lung, and spine. Like what we do every day for the patient, we put the Phantom on our CT scanner, CT simulator, acquire CT scan, and then transfer to a treatment planning workstation and optimize the plan and calculate the dose. Then move the Phantom to the RadioSat machine and perform a ClearRT scanning, transfer the image, recalculate the dose, and compare the 2 results and see whether we have different results or any indication of serious dosimetric impact. Looks like we don't see any severe dosimetric impact in the shoulder region, and also for the spine, lung, nasopharynx. But we do see some indication of dosimetric uncertainty due to the artifacts in the brain region. So I guess we have to be careful when we use the ClearRT, especially with all those artifacts potential affecting the dosimetric calculation for adaptive radiotherapy. So in summary, ClearRT actually gives us much better image quality for post-surgical application, for image matching, and under our current situation, by selecting the imaging protocols, we do not see any significant advantage in the radiation dose saving to the patient. Other than that, if they select another imaging protocol, they may see a different result. So it may vary. The scan time is much shorter. That definitely help to increase the patient throughput, increase the patient comfort, and potentially help the clinical workflow, especially when we have to repeat the scan and for the patient with long scan length coverage, then that will definitely help the workflow. We see artifacts like what we encounter in any diagnostic CT, and all those artifacts may affect the positional verification and also for the adaptive radiotherapy procedure. So we have to proceed with caution and see whether we need to switch back to the Mvct. We get higher overall score from the RTT feedback, so they really like it. And actually, they use most of they use ClearRT for most of the patient, except for some exceptional cases. For example, one of the case with a metal implant in the neck close to target regions, the artifact was so severe then that we couldn't use ClearRT, and we had to switch back to Mvct. So one of the questions people may ask is whether ClearRT is a replacement for Mvct. According to the evaluation we have done so far, I don't think it is a replacement. You need both. ClearRT can be used as a workhorse doing most of the case every day, but if you have some patient may have severe image artifacts due to beam hardening or due to metal implants, then you still need the Mvct to do the positional verification. That's all I want to share with you today. Thank you.